Welcome back, everyone. We hope you enjoyed your lunch and are ready for the next set of presentations this afternoon. Without further ado, let me introduce our chair for session 3 on GI updates. Please welcome Dr. Sharif Mossad, consultant pediatrician and neonatologist, resident of Pedia, Dubai. Dr. Sharif, stage is yours.
Hello, everyone. Good afternoon. I know this is the session is after lunch. It will be a little bit heavy, but that's why we are choosing GIT after in this session after lunch. So before we are introducing our eminent speaker, I want to extend my thanks and appreciation to my brother Dr. Junaid Khan and Dr. Ayman Rahmani for their kind invitation to me as a moderator for this session, and congratulations for his really excellent organization by MENA company, and very nice place, luxury place really. So thanks for them, and we are hope for a great success for the conference. Let's start our session by Professor Dr. Eric Ekenwald. Professor Eric is a professor of pediatric and chief division of neonatology at the Children's Hospital of Philadelphia, University of Pennsylvania in USA. He is currently the Thomas Frederick McNair Scotch Endowed Chair and Professor of Pediatric at University of Pennsylvania, as we said. Professor Eric, he is an editor of the manual of the neonatal care, and we have good news that the 9th edition, it is already published and now in the market, and you can even order by Amazon. So let's welcome Professor Eric. He will speak about the very important topics, and really we need to hear about this probiotic in NICU. Yes, no, or maybe. So let's welcome Professor Eric.
Well, thank you very much. And I'd first like to thank Dr. Junaid and Dr. Ayman for having us here. And I think this is my 4th time at this conference, and it gets better every time, even though I think we spent at least 2 of them completely virtual. But it's great to be back in the UAE and to be able to see some of my colleagues that I've met over the years. So I have no conflicts of interest to disclose, but I should let you know that I am the current chair of the American Academy of Pediatrics Committee on Fetus and Newborn. So you've seen a lot of references to the committee statements, and so if you don't like what's in them, you can blame me after the talk. But I think that I think the committee is a very important role within the AAP to put out clinical guidelines for neonatology. So I'm going to talk in the next 25 minutes about the neonatal microbiome and the role that probiotics may play in the care of our most premature babies. And when we think about the establishment of the microbiome in the neonate, obviously babies who are born vaginally will have some microbiome that's established through their mother's birth canal, but things that have been known to influence the establishment of the microbiome, particularly in very preterm babies, include the mode of delivery, whether or not the NICU employs aggressive skin-to-skin contact, instrumentation of the baby, NG tubes, endotracheal tubes. The presence of chorioamnionitis in the mother is an obvious thing, and then whether or not the baby is breastfed or receives formula. And lastly, what's the NICU flora? So the baby is going to be colonized with those things that are present in the NICU. But probably the most important thing is the role of antibiotic use in the individual NICUs. So this graphic shows what happens to the neonatal microbiome with antibiotic therapy. And And if you look at the bottom two panels, each color represents a different type of organism. And the bottom part of this is when the mother and the baby both receive antibiotics. And you can see that over time, at 2 days, 10 days, 30 days, and 90 days, and again, paying attention to the very bottom panel, you can see that the types of organisms that colonize the baby's GI tract becomes very monotonous. And that effect lasts for many, many weeks. And what I like to look at this is to say, well, the neonatal microbiome is supposed to be quite diverse, like this forest you see in the upper panel. But after the baby gets antibiotics, it looks like this burnt out forest. The organisms are all dying off and become very sparse microbiome. And then as it recovers, it becomes very monotonous, as seen in this forest here. And this is one way of imagining what's happening when babies are receiving antibiotics. And this effect can last very, very long. But we also know that from a number of different studies that if you give probiotics, which I'll define in a moment, it does change the preterm gut microbiota. And in these two panels, you can see, again, each color represents a different type of bacteria. And you can see that in comparison to babies who received a placebo, the babies who have received the probiotic have a different distribution of microorganisms, particularly this bifidobacterium, which is in the lighter blue, but also a number of different pathogens are less represented in the microbiome in a preterm baby who has received probiotics. So what are some of the potential beneficial effects that are thought to be due to probiotics when they're given to a preterm baby? Well, there are a number of things that are hypothesized, including improvement of the intestinal barrier, prevention of pathogen attachment, production of antimicroorganism substances, and probably most importantly, it's believed that probiotics help modulate the immune response. And we know that a hyperactive immune response is particularly important in the pathogenesis of necrotizing enterocolitis. And so probiotics may, through these mechanisms, help prevent necrotizing enterocolitis. And there have been a number of different studies that I'm going to review for you over the course of this talk that have tried to demonstrate if some of these effects are true clinically. So what is a probiotic? Well, the International Scientific Association for Probiotics and Prebiotics state that if a probiotic is termed a drug, it has to have an indication to treat or prevent a disease, and it requires that it has defined strains of a live microbe. There's proof of delivery of a viable probiotic at an efficacious dose at the end of the shelf life of the product. And its risk-benefit assessment to justify use is based on appropriate trials to meet regulatory standards for a drug. And there are a number of differences in regulatory standards across the international community, including what's defined as the number of colony-forming units within a probiotic drug. There are claims of benefit that are not strain-specific, and we're going to talk a bit about that, how different strains may be important in the use of probiotics. And also, there should be the intent to support the healthy gut microbiome versus trying to prevent a disease. Because if you're giving a probiotic as a drug, you're trying to prevent a disease. Now, what we wrestle with in the United States is that all probiotic products are available in the US are categorized as dietary supplements or as foods for special dietary use. And so we don't really know necessarily what's in those products. And so if you're using a product that is designed as a food product or designed as a dietary supplement, it's not regulated to the same degree as a probiotic that's specifically designed to be a drug. And that's important, as we'll talk about. So the first thing I'd like to do is just to review a couple of large clinical trials of probiotics, two of the largest ones that have been done in the last decade, to give you the sense of what information is out there. And the first trial was published in 2013. It's the ProPrems trial, or Probiotics in Preterm trial. And this was conducted in Australia and New Zealand. And it had targeted recruitment of 1,100 babies, less than 32 weeks or less than 1,500 grams. And they used a multiple probiotic product that included the three organisms seen here. And the primary outcome of the study was the reduction in late-onset sepsis, with secondary outcomes including necrotizing enterocolitis. And I've put the results here in the table, and you can see that they found no effect on late-onset sepsis with a probiotic at 13.1% and the placebo at 16.2% with a non-significant p-value. But they did find a difference in the overall group of babies that were enrolled in the incidence of necrotizing enterocolitis. The probiotic group was 2.2% and the placebo group was 4.4% with a p-value of 0.03. Importantly, that effect was only seen in babies who were greater than 1,000 grams. And you can see here from this table that there was no difference in the incidence of necrotizing enterocolitis between the babies who received probiotic and placebo in the babies that were less than 1 kilo. And that's going to be a common theme throughout this talk. The next trial I'd like to talk about was published a couple of years later, and this was the PIPS trial of the probiotics in preterm babies, and this was conducted in England. And they had a targeted recruitment of 1,315 babies less than 32 weeks. And they used a different probiotic product with only a single bacteria, and their primary outcome included late-onset sepsis, necrotizing enterocolitis, and death. And unlike the ProPrems trial, you can see here that they found no effect on the incidence of necrotizing enterocolitis, almost identical between the probiotic and the placebo group of 9.4% to 10%, and the late onset sepsis rate also did not change. So these are two large trials that had an intervention of using a probiotic versus a placebo. And so what do we know from these trials of the evidence in extremely low birth weight infants? Well, both trials enrolled about half of the infants that were in the trial were less than 1 kilo. They used different interventions, and they had similar results for the babies less than 1 kilo. As I said, the PIPS trials had no effect, and the ProPrems trial had no effect in the babies that were less than 1 kilogram. So a lot of these studies now have been collated, and I've presented the two biggest trials, and I'm going to go through what the Cochrane meta-analysis has shown from all of the trials that have been done to date. There have been an enormous number of trials looking at probiotics with over 10,000 babies enrolled. And when you look at the overall results, they suggest a reduction in necrotizing enterocolitis with a risk ratio of 0.54, with a number needed to treat of 33. So a fairly robust response to probiotics. In these meta-analyses, probiotic use was also associated with a reduction in late onset sepsis and death, and there was no evidence of an effect on developmental outcome. So when we look at those results, we would say, yes, we absolutely should be using probiotics in the NICU. But there's a number of different caveats to that conclusion. Mainly, that few of the trials that have been done have provide data individually for extremely low birth weight infants. And when they are available, these analyses did not show effects on necrotizing enterocolitis, death, or serious infection. So again and again and again, we see that the infants who are most at risk for developing necrotizing enterocolitis, probiotics seem to have no effect. And we're going to try to dissect why that may be true in the rest of the talk. So when you look at the different Cochrane analysis over time, they've now backed off on what their conclusion. In 2011, they concluded that the updated review of available evidence supported a change in practice, namely, we should be giving probiotics. In 2014, the conclusion was exactly the same. But with the addition of the ProPREMs in the PIPS trial in 2020, the review changed its recommendation to say that given the low to moderate level of certainty about the effects of probiotic supplements on the risk of NEC in extremely low birth weight infants, further large, high-quality trials are needed to provide evidence of sufficient quality and applicability to inform policy. So they've used the data as it's become available, backed off on their statement to say, well, maybe we don't have enough information about what probiotics do in the extremely low birth weight population, and we need more studies to inform that issue. So much more recently, there have been two observational studies that were done in the United Kingdom, one published by Claire Robertson and the other by Claire Granger in 2020 and 2022. And these are very interesting studies because they're almost identical in their design, in their intervention, and as I'll show you, with very different results. So in the 2020 study, they enrolled babies less than 32 weeks and less than 1,500 grams. Similar in the 2022 study. There were about the same number of babies with about the same gestational age and birth weight in both studies over the same time frame using exactly the same intervention with probiotics, Influorin and LB2, with the issue with NEC was the final result that they were looking at. And these were before and after studies trying to see whether there was an effect on the incidence of necrotizing enterocolitis in their unit after they introduced probiotics. And so what did they find? Well, they both explored the impact of this Influorin and Labinic sequentially in UK units. So they looked at before they were using the probiotic and after, and asked the question what happened to the incidence of NEC. And the two studies found exactly the opposite results. One, on the left-hand side of the screen there, shows that in one unit, in the 2020 report, the incidence of NEC was significantly decreased at an adjusted odds ratio of 0.44 with a p-value of 0.14. But in the other study, again, absolutely identical to the 2020 study, there was no effect on the incidence of NEC with a p-value of 0.73. So absolutely no signal that probiotics were effective. So why might that be the case? And I think one of the things that you can think about is that different units have different risks and maybe then have different effects of probiotics. And this is just some of the differences between the two different units in the 2020 report and the 2022 report. You can see that the baseline incidence of medical necrotizing enterocolitis was different. The incidence of late onset sepsis was different between the two units. The differences in spontaneous intestinal perforation, mortality, use of drains versus laparotomy, and both in the postmenstrual age at diagnosis of NEC. So the units, even though they were enrolling similar types of patients, what those patients were exposed to in that unit was different. And perhaps that explains the differences between these two studies and their results. Because there are multiple differences between units that may outweigh probiotic use, and that can include how much antibiotics are used, what types of feeding practices, whether formula or breast milk, what the NICU environment looks like, including the incidence and success of hand hygiene compliance, as well as other bacteria that may be in the unit's flora. So units are different, and because of that, that may outweigh any potential benefit of probiotics. And I think that that's one of the reasons why you see these disparate results between these two observational studies. And the other thing that's important, even though these two studies use the same probiotic regimen, we know that strains also matter. And what I've shown here is in green, the strains that have been associated with a decreased incidence of NEC. In blue, the strains that have been associated with a decreased incidence of late onset sepsis. And in red, the strains that have been associated with differences in mortality. And you can see there's very, very little overlap. And so I think what we don't understand is what the right probiotic is, because different probiotics may have different effects in different NICUs. And so this information informed the clinical report that was published in 2021 by the Committee on Fetus and Newborn, with the first author, Brenda Poindexter from Emory University. And we analyzed this data, and we came up with the following recommendations for the United States neonatologist. And we said that current evidence does not support the routine universal administration of probiotics to preterm infants, particularly those with a birth weight less than 1,000 grams. And the most recent trials, as I said, showed that there was no reduction in NEC in infants at highest risk. We also know that our pharmaceutical grade product is not currently available in the United States. And there's some questions about long-term safety, because safety has not been a major conclusion of some of the, or a major issue that was addressed in some of these studies. We also suggested that centers making the decision to administer probiotics to select preterm infants should discuss the potential risks and benefits with parents, and should consider a formal informed consent process. And clinicians in the US need to be aware of the lack of regulatory standards for currently available probiotic preparations. And I think that we finally concluded that centers choosing to administer probiotics should carefully document outcomes, particularly adverse events and any issues with safety. So there are a number of other statements on probiotics, and in general, they're pretty consistent. The AAP Committee on Nutrition about a decade ago said that all probiotics cannot be generally recommended. ESPGHAN in Europe recommended against the use of certain probiotic preparations given safety concerns and uncertainty of the evidence. The Canadian Pediatric Society said that probiotics may help to prevent NEC, but there's currently no evidence for infants weighing less than 1 kilo. So I think that the frame has changed, I think, from yes to now maybe, because, and I don't know if the answer is no, but we know that the kids at highest risk don't appear to benefit from currently available probiotics. So these are now a few of my own thoughts about this, and I think that if you are going to use probiotics, I think the safety is a priority. There's a potential infectious risk with probiotic-associated sepsis, which I think is very, very low. They're in the form of case reports, and none of the cases, none of the randomized trials reported that as an issue. We also know that there is cross-colonization among infants within the same units. About almost 40% of infants assigned to the control group were cross-contaminated in the PIPS trial with the specific bacillus that was used as the probiotic. So organisms are being shared amongst infants that even if you don't intend to give probiotics to them. We also know, at least in the United States, there's been some reports of probiotic products contamination with Salmonella, Rhizopus, and Penicillium species. And there's at least several case reports of gastrointestinal mucormycosis reported because of contamination of the product, again, because it's a food product and not a pharmaceutical. And I think that what a lot of this tells us is that it highlights the need for better reporting of adverse and serious adverse events when you use probiotics. So I'll conclude with some of the knowledge gaps of using probiotics in the NICU. First, I think, as I've said several times now, the effectiveness of probiotics in preventing NEC or other adverse outcomes in extremely low birth weight infants is really unclear. And I think we need additional large randomized placebo-controlled trials in that specific population to help us answer the question. There may be subsets of infants who might benefit the most from probiotics. That's not the less than a kilo, but if you're in a unit that has a relatively high incidence of NEC in the babies who are more than a kilo, thinking about using a probiotic preparation in that specific population may make sense. There remains enormous uncertainty around the optimal probiotic strain or combination of strains, whether it should be multiple versus a single strain preparation. Most of the best results have been seen in multiple strains rather than a single strain, and I think that if you are going to use a probiotic, I would recommend going to a multiple strain product rather than a single strain product. And we really don't have any idea right now through the randomized trials of optimal dose and duration of treatment. And finally, none of these trials have included long-term safety of the alteration of the gut microbiome. We know from studies that have been done in multiple places, including in Philadelphia, that antibiotic use early in life affects weight gain trajectory. So changes in the microbiome may have long-term health effects that we're not currently measuring by the use of probiotics in very preterm infants. So I'll just conclude by saying what should be done before you use probiotics in your NICU. Well, first, I think it's incredibly important, again, to encourage maternal breast milk provision. That's been shown to have a significant benefit in the prevention of necrotizing enterocolitis. In the United States, there's been very aggressive promotion of donor breast milk, particularly in the very preterm population. But I think in the UAE, we should really be encouraging maternal provision of breast milk and trying to avoid formula as much as possible. There's been some good results that have shown that a feeding protocol, almost regardless of what it is, helps prevent NEC in your unit. And you need to develop a local feeding protocol and make sure your neonatologist and other care providers are following it and not going off on their own and having their own way that they provide nutrition to preterm infants. Attention to milk preparation technique to avoid contamination, I think, is extremely important and should be done in a sterile environment if you're mixing additives into breast milk. And lastly, I think that probably the three other most important things is avoiding prolonged antibiotic therapy when blood cultures are negative, and we're going to talk about that tomorrow, why that may be important. I didn't talk about acid suppressive medications. I've talked about that at this conference before, but that also has been associated with an increased risk of necrotizing enterocolitis, probably due to the effect on the microbiome as well. So those should be avoided in the infants at highest risk. And finally, environmental controls such as hand hygiene and other activities to decrease late onset sepsis risk, and most importantly, colonization with pathogens in the NICU is an important first step prior to making the decision to use probiotics. So if you are going to do it, make sure you've done these things first to be able to have the most likely lowest rate of necrotizing enterocolitis. So with that, I will thank you for your attention. And again, it's a pleasure to be back here in Abu Dhabi, and I'll look forward to your questions.
Thank you very much for Professor Eric for a very interesting and informative lecture. Again, I want to thank my dear brother, Dr. Junaid and Dr. Ayman, because when I thank you, you are not here. So again, so thank you, of course. Let's to introduce next speaker. The next speaker, it is well known and not need any introduction. So just a brief introduction that Dr. Faris Shadid is a consultant neonatologist and HOD of the neonatology department in Kanat Hospital in Rain. And Dr. Faris also, he has a very long biography and long CV. He have more than 70 publications, and he's have many awards from international and national conference. Dr. Farisi will speak to us about very interesting and new. You know all the best is the breast milk. So we are now speaking about something very new, human-derived breast milk fortifier and exclusive breast milk diet, yes or no? So Dr. Faris will answer this question.
Thanks, Dr. Junaid. Thanks, Dr. Ayman. Both direction, Ayman, Junaid. Thank you very much. The subject on exclusive human milk diet and human-derived fortifier is stirring lots of discussion, and I know I received many emails from eminent colleagues, and we discussed through email what should we do considering the cost. So Dr. Prof. Eric was more intelligent than me. He said probiotic yes, no, and maybe. Myself, I kept it yes or no, so I'm stuck to answer yes or no. All right. My objectives will be to present the types of human milks, then to answer the question, mixed feeding what we are all doing, we are given mother's milk plus bovine fortifier when we have mother's milk, or preterm formula when we don't have mother milk. This is called mixed feeding. That mixed feeding, yes or no. Then another higher level of cost would be only human milk, meaning when mother brings milk, we'll give her milk with bovine fortifier. When she doesn't bring milk, so we will buy at high cost the Prolacta. There is only, I have to name it because that's the only available milk at high cost. This is a human milk diet, but not exclusive human milk diet because we are using bovine fortifier. So we benefit from all adjectives of human milk, but we have bovine fortifier. The third one would be when mother brings breast milk, we'll add the fortifier that's human at very high cost. And when the mother doesn't bring milk, we'll bring milk also at very high cost. This is a very expensive alternative, yes or no. So these are blunt questions that are coming up. So I did not receive any meeting invitation, any hotel, any accommodation, not money communication, not at all, unless you took it for me. So I have nothing to disclose. All right? These are the types of milk. First one is the best, is the fresh milk. Fresh milk is different from frozen milk. You should stimulate the mothers when they come to the unit to express and give that milk over 24 hours because it contains all the cells. Freezing will kill the cells. Probiotic will be killed. Stem cells, white cells, and all cells that are in breast milk will be killed by freezing. But also, these are the three other types of methods where the milk is pasteurized. One of them is the Holder pasteurization. That is milk banks, 62 degree, 30 minute. Then vat pasteurization, that's the one done by Prolacta. Companies, not to compare, but when you have tons of milk from cows, you're not gonna do it with small bottles. You go to big factory, you put them all together and you do something called vat pasteurization. It is 30 degree, 62.5 degree, 30 minute. And this is how they claim, because it's cheaper for them to do it this way. This is how they claim it's compatible with Islam because they combined thousands of samples together so nobody will be exposed for longer, for full feeding from that milk. Vat pasteurization, then because pasteurization itself loses some of the biological component of milk like immunoglobulin and other elements. So some people try to reduce the duration from 30 minutes to few seconds, but increase the temperature. That's ultra high, short time pasteurization. So these are pasteurization. Now, pascalization is not yet applied to human milk. This is when you apply very high pressure at zero temperature. And then sterilization, there is a lady who used to work with Prolacta. She moved out and now she's creating milk that can stay 3 years at room temperature. That's RTR sterilization. This is very high temperature, lowish pressure for 5 minutes. You lose many of the product. What's available to us now? Nothing much. Because in the Islamic world, we don't have milk banks. We have only 1 year or two ago the milk that came from that company quite highly expensive. Plus we have the fresh milk and frozen milk from mother-owned milk. So I'll have to select among those that are available to me. So to show the difference, only fresh milk contains all these cells. You know, now people are talking about stem cell treatment that will go to the brain, to the lung, to prevent chronic lung disease, to develop again some neurons that have died, or so they go to every organ. These are available only in fresh milk. So I would stimulate people to get fresh milk more than frozen milk from parents. Now, milk contains more than the proteins for nutritional component. We talk human-derived versus bovine-derived fortifier. That's when we talk about the nutritional component of protein. But here, we have all growth factors that go to the brain, to the gut, to the liver, everywhere. They exist to lesser amount in frozen milk, but nearly equal to the fresh milk, but also lesser than frozen milk by pasteurization. You have also many bioactive components. Some of them are microbial factor, immunological factor, metabolic factor. This is not my subject. They are reduced by 20 to 50% due to pasteurization, and they are reduced but mildly during to freezing and thawing. So different milk are different. We cannot compare them and say this is all breast milk. Now, who am I to come and say that all of those people are wrong? So WHO, American Academy, Canadian Pediatric Society, Japan Pediatric Society, ISPEGAN, NASPEGAN, all of them recommend mother-owned milk up till 6 months of age. And then when you don't have mother milk, they don't say to give formula, they say to give a donor milk, meaning milk bank. No way they would go to 6 months, it could cost million or billion to do it till 6 months. So it would be donor milk, but unscreened donor milk from mother to mother, they don't recommend. So based on this, we need to push for milk from donor milk if we can, and otherwise I'll address the issue of those companies. Look at this part of the world here. All this area of North Africa, MENA, Middle East, North Africa, Gulf, no breast milk bank. So not available to us. So what we should do and might do, I would recommend here, it's a study on the Pediatrics Medical Group site, 197 NICU. Some of them, they have 90% provision of breast milk at 30 days of life, and others would have the lower part, which is 35%. So one of the recommendations I would suggest that DOH, before they pay any milk that costs lots of money, they should require from every unit to have policy procedure and should provide at least, I would say, 60%, because 60% you put you less than percentile 50. So any unit should be able to show that they have provision of some breast milk by day 30 of life before they talk about getting money for milk. So let me address the issue of exclusive human milk diet. Mother bring milk, then I have to fortify it with a human fortifier. It cost me huge. This is using the calculator from the company, but using my population of 4 years patient less than 1250 gram. So the cost will be anywhere between 45 to 92,000 dirham. That's if mom bring her milk, it costs her the set. But if mother doesn't bring her milk, I would have to buy the milk from the company. It costs nearly the same. Whether she bring her milk or not her milk, it costs nearly the same, which is between 50 to 100,000. So applying it to my population that I have between January 2019 to December 2022, I got some 67 babies that delivered, that went home alive between those age group below 1250 gram. My total revenue was 24 million. And the cost of EHMD, if I apply it to those patients one by one, I applied it, it would be 26% of my whole budget. The average cost per patient is 95,000. So, no. That's no if I will give EHMD up till 33 plus 6 weeks. But there is a way, many people around, they say, what about giving till 32 weeks, 31 plus 6 weeks? So here it is, if I do it till 31 plus 6 weeks, I stop at 32 weeks. It would cost 14% of my budget, which is half nearly of the previous one, which will be still 50,000 per patient. This one, because I know it's 2 o'clock and people will sleep, I'm giving them the conclusion before we start the talk. So if they sleep after, they get the conclusion. This I take out not because of the cost, because I will demonstrate to you that a human-derived fortifier does not make a difference to the major outcomes of prematurity. So even if you have the money to buy it, you're talking EHMD because you're giving human-derived fortifier, and that's what drives the cost. So if that doesn't make a difference, as I will show, then there is no place for EHMD. Now, what about that option? When mother brings her milk, I add to it bovine fortifier. It costs me nothing. But when mother doesn't bring milk, I buy the milk, since I don't have milk bank. This is a proposal that I would suggest to you, and I might suggest to DOH, and we'll talk why. That would cost in my unit 7% of my revenues, so I wouldn't do it unless DOH pays for it. And that would cost 25,000. So we went from 100 to 50 to 25,000. This would be the proposal that I would suggest to do. And the proposal that I would suggest to take out also is what we all do now, which is when mother brings milk, we put bovine derived, that's fine. But when mother doesn't bring milk, we do preterm formula. I will show the evidence that we all know the evidence that preterm formula increase the risk, but I will show the evidence of cost effectiveness. So my suggestion would be to go away from what we're doing now, which is preterm formula, to replace it by the choice of before. Sorry. So, how to go back? No, it's going up. Here. So these are the available choices. If mother brings milk, either we fortify it with a human fortifier at a cost of 47,000 in average, or we fortify it with bovine at nearly zero cost, 700 dirham per case. When mother doesn't bring milk, we'll buy preterm formula at zero cost nearly, or we buy the Humavant, which is the only available milk at a cost of 55,000. So there are only 3 combinations. First combination is what we are all doing. Human milk plus bovine fortifier, and when we don't have milk preterm formula, that costs nothing. It's like 700 dirham. The highly expensive one would be when she brings milk, we put human derived at very high cost, and when she doesn't bring milk, we buy milk at very high cost. That costs 50K. The third choice which is there is when mother brings milk, we put bovine derived. When she doesn't bring milk, we buy the Humavant. My suggestion to you, then please kill me at the end, wait till the end and listen, then kill me, is to eliminate the EHMD and to eliminate the mixed feeding and to keep that one. Mother's milk normally mother milk contain 1 gram of protein. Mother of preterm baby 1.1. First few days more, but later on 1.1 gram of protein. If we put a bovine fortifier, the amount of protein that come, if we put 1 gram in 25, we would put more than half of protein originating from bovine. So one could say that's heavy, 56% of protein coming from bovine. Yes, but all elements of feeding, like the immunoglobulin, all feeding component, all immunological component, all cells, everything is still breast milk. So we didn't change anything to the breast milk. She's still benefiting from breast milk, except the proteins are co-protein. But also the issue with the Humavant, the way to fortify, you push away how to fortify it till make it 26 calories per deciliter, per 30 mil per ounce. You put 70 ml of breast milk, you push away 30 ml of breast milk, you put instead of it Humavant. So if a mother is bringing fresh milk and that contains all stem cells and white cells and probiotic and everything, we're pushing away 30 out of 100 and replacing them by Humavant. So to get that concentrated milk at 2.9 gram of human milk. So both of them have issues, but let's not make it bigger than it is. The fact of giving bovine fortifier, we didn't lose anything from breast milk by adding the bovine. We're adding some. So does a human fortifier have a benefit over bovine fortifier? I looked at all literature and I asked even the company for every literature that they can have for me. And I found 3 randomized trials, 2 blinded, 1 open, some non-randomized controlled trial, some prospective, some retrospective studies. These are the available studies. And none of the studies shows any difference in in major outcomes. So between those given human fortifier versus bovine fortifier, same neck, BPD, IVH, and death. In the study of O'Connor's, which showed no difference, after the study is finished, it wasn't a primary, ROP wasn't a primary or a secondary outcome. They explored their data after they finished collecting the data. They found an improvement of ROP, but that was only exploratory, and they didn't even adjust it for other risk factors of, so it's unadjusted p-value. So I will say hypothetically, it might improve ROP, but it wasn't primary or secondary outcome in the analysis. In another retrospective study with historical control, there was an improvement on the rate of ROP, all right? Sepsis, one of the studies shows improvement that was also exploratory analysis. It wasn't primary or secondary outcome. And other no significant difference, length of stay also. What about the feed intolerance? No difference in time to achieve full feeding, feeding intolerance or growth, no difference. In all randomized trials, there was no difference. But in one retrospective cohort, there was better time to achieve full feeding. So I would say only in a retrospective study with historical control, there was some benefit. Otherwise, every randomized trial showed no difference. Amino acid profile lab result, amino acid, nitrogen, and fat balance, the same. Fecal calprotectin, controversial. One study showed decreased, another showed no difference. And bacterial growth, one study, they put in the lab bacteria and they add to it either bovine or human. They found that human will inhibit the bacterial growth while bovine did not. So in summary, the $1 million question, human or bovine fortifier, in randomized, non-randomized controlled trial and prospective cohort, no difference in neck BPD mortality sepsis. There is a hypothetical benefit in ROP, no difference in growth, feeding intolerance, or time to achieve full feeding, no difference in amino acid, nitrogen, fat balance. Human fortifier inhibited bacterial growth in a lab guttery thing, but not the bovine, and non-conclusive fecal calprotectin level. So if with all those information I tell you human fortifier cost 47,000 and bovine fortifier cost nothing, which one would you choose? So to me it's a clear cut. There is no place for human fortifier to be added to the human milk for now, considering its cost. So if there is no place for human fortifier, then there is no place for exclusive human milk diet. We remain with only 2 choices, either mixed feeding, which is mother milk with bovine versus preterm, or human milk diet. Whenever mom doesn't bring milk, I'll buy the milk at high cost. What would be my choice? One of them costs 700 dirham per stay, and the other 25,000 dirham. I will put to you, and you'll follow me if you wish, that I will take out our present practice of giving mixed feeding. I will accept that practice of purchasing the milk. And why? It doesn't need much talk to demonstrate, like it's demonstrating water is wet. All of us know that breast milk prevents neck. Prof. Eric showed it clearly. So studies, Cochrane reviews, have shown that neck is decreased with an odd ratio of 0.33. ROP, interesting, ROP is decreased in a marked way with an odd ratio of 0.31 with human milk. BPD decreased with an odd ratio of 0.78. Death and sepsis is sort of controversial from study to study. There is a trend toward decrement, but it didn't reach significant. When we want to talk about breastfeeding, what harm breastfeeding and breast milk is when we give wrong information. So many other aspects are not improved by breastfeeding, like length of stay. Cognitive scores for now it's not conclusive that it improves IQ, IVH, weight, head circumference, feeding tolerance, and time to full feeding. So there are enough studies comparing exclusive milk versus mixed milk versus formula. All of them showed that NEC is decreased. But one relevant subject, I don't know why, but it's very interesting, is the last study here. Last study. They compared mixed feeding with formula. They found that mixed feeding harm. Like if mother bring milk and when she doesn't bring milk, we give formula, it's better to give formula. Nobody will say when mother bring milk, don't give the milk. But that study showed that formula is better than mixed feeding. Now that's one study. At which strengths you take it, I don't know. But one day Dr. Junaid, Wake Up Junaid, was giving a talk and he said that every 10% increase of feeding will decrease NEC by 10%. I said, what is he saying? But well, you were right. You know, when I looked at this study, 2009, on 2007 to 2 extreme low birth weight infant, it shows a dose-dependent improvement of NEC. And it says, the lower line, the hazard ratio would decrease by 17% for every increase of breastfeeding by 10%. And if you feed more amount in total, you decrease also a lot. So it is dose-dependent. So what are now my remaining choices? If we say that breastfeeding decreased the combination of NEC, ROP, BPD at least, maybe death and sepsis, then to me, we need to work on, if it is cost effective, we need to work on getting the breast milk all the time. Breast milk doesn't mean human milk derived fortifier. So to conclude on my aspect, on the aspect I said, what is this here? I'll take this slide. If I give you 100 preterm, all of them below 1250, very small. Most of you agree that the rate of NEC is 10%. You might have less NEC in your place, but you might have also a larger weight group. So the rate of NEC 10%, the rate of severe ROP would be 13%, moderate BPD would be 30-40%, but moderate to severe BPD may be 15 cases, considering that odd ratio is 0.3, 0.3, and 0.8, but odd ratio exaggerate relative risk. So I said, let's go less than that. Let's say these are the cases prevented. So to be quick, I would say the total number of major complication prevented would be 17. That means the number needed to treat is 5.8, say 6. So number needed to treat 6 is very beautiful. If a case cost 25,000 times 6, it would be 150,000 to prevent one case. How does this compare to Synagis? Dr. Ayman presented us, not Synagis, but the impact of RSV. In our case, we need 150,000 to prevent one case. In Synagis, the number needed to treat, not to prevent major disease like NEC, ROP, BPD, severe cases. It is only to prevent one admission to the ICU. The number needed to treat is 17. Considering that they do 5 doses and every dose in average 3,000. So the cost for Synagis is 255. While the cost for preventing one major case is 155. This is like a pseudoscience because it's not a good study on cost effectiveness. But you have also cost gained by having prevented those diseases. So the total cost is not 150,000, it's much less. So considering that, I would say it seems to me cost effective to buy the human milk diet, but not the human milk fortifier. You know, I wanted to know for studies of QALY, how much is the life cost in the UAE. Then I couldn't find any study. Then I said, okay, let's go to WHO. WHO says the GDP per capita. If you take the GDP per capita, this is very conservative. And if you want to be generous, you accept 3 GDP per capita. So the GDP per capita in the UAE is $45,000, 165,000 dirham. And that amount is distributed over 60, 70 years of life. So I would say it is less than 1 GDP per capita, which is very conservative cost for life to implement. My conclusion, that would apply only to below 1250. Yes, for bovine-derived fortifier. Yes, for human milk diet, if the cost is covered by DOH. Remember, Synagis is covered by DOH. If Synagis was to be covered by my DRG, I wasn't going to do it. So, yes, for human milk diet, if covered by DOH. If not covered, no. No for human milk-derived fortifier. That means no for EHMD. No for preterm formula, that means no for mixed feeding. If I may put some recommendation, but that has to be passed through the eminent people here to agree or disagree, I would suggest that DOH to perform a better cost-effective analysis than mine here, to cover the cost of human milk diet for birth weight below 1250 up till 31 plus 6 weeks, not to cover the cost of human-derived fortifier, DOH to require 60-70% preterm to receive mother-owned milk by day 30, meaning they need to check that you have policy procedure KPIs before you get money. And then this is totally another subject. One of my colleagues, Dr. Tawakkul, one day gave that talk. There is ways to enable human milk bank in the Islamic world, respecting Islamic prerequisites. Thank you very much. It's both ways.
Thank you, Dr. Faris, for the very informative and expensive lecture, actually. I would like to thank Dr. Ayman Rahmani and Dr. Junaid Khan for this successful event, actually, and we are always happy to be part of your events. And it's really valuable events for all neonatologists. I'm Dr. Mohammed Cheta. I'm a consultant neonatologist and head of department at Saudi German Hospital, Dubai. And it's my pleasure to introduce the next speaker, Dr. Mustafa Abdul Latif, and he's a consultant in ICU at Tawam Hospital. Dr. Mustafa has Arab Board certification in pediatrics and neonatology, and he's a member also of Royal College of Pediatrics and Neonatology, and he has European Board certified in pediatrics and neonatology. Dr. Mustafa will talk to us today about new AAB guidelines of management of neonatal hyperbilirubinemia. If you see these curves before, it's really scary curves for me. I couldn't apply until now. I'm going just near to it, but I'm really eager to hear Dr. Mustafa what he will say to us about it. Okay, thank you. Here, Dr. Mustafa.
Assalamu alaikum. Thank you, Dr. Muhammad, for your nice introduction. And I would like to thank the organizing committee for inviting me to present the recent AAB guideline for management of neonatal hyperbilirubinemia, 35 weeks and above. Actually, after this costly introduction, a costly presentation by Dr. Faris, and also scary introduction, and I have now 25 minutes to present 48 pages, so it will be a little bit hectic. So I think maybe we can start from conclusion before, as Dr. Faris said. So initially, the AAB published the initial guideline in 2004. The first revision taken place in 2009, and this is the second revise. Many changes were suggested by this guideline. Phototherapy, for example, and exchange transfusion chart is totally new, and also new terms were introduced, like escalation of care and Delta TSP and Delta TCP. We'll go through this during my presentation. In this clinical practice guideline, they address the following issue, and this will be our main topic and our main objective in this presentation. So the prevention, risk assessment, monitoring, treatment option, and follow-up plan with parents' education. As a risk of kernicterus and timing of discharge, policy can differ among the country, so the committee in AAB recommend caution and incorporation with local expertise to apply this guideline outside the US. This guideline contains 25 key action statements. We'll go through this key action statement quickly. Initially, statement 1 and 2, a little bit, they introduce complicated pathway to manage the newborn with positive maternal antibodies to guide the management plan. The bottom line here, now you have to identify the neonatal direct antiglobulin test for positive or unknown status for maternal antibodies. Now, in case we have neonatal DAT positive and maternal antibodies are positive, both of them, and mother didn't receive anti-D, you have to measure the bilirubin immediately and every 4 hours initially, then every 12 hours. AAB still encouraging using breastfeeding on demand in the first hour of life and discouraging the use of oral supplementation with water or dextrose water. Now, moving for monitoring, so frequent monitoring is recommended for infant who has any of the following risk factors. Similar risk factor before, only they add two new, the Down syndrome and macrosomic baby. This is extra. Now moving for assessment, we have 3 options for assessment. Either we'll assess visually or through transcutaneous bilirubin measuring or measuring serum bilirubin. Now, visual assessment should be done for all infants at least 12 hours following the delivery. And then, whenever baby looks jaundice in the first 24 hours, bilirubin measurement should be done immediately. Universal screen of bilirubin still recommending, and bilirubin measurement should be done between 24 to 48 hours of life or before discharge if this has happened earlier. Now, initial first line of screening is the transcutaneous bilirubin. But serum bilirubin should be sent whenever the transcutaneous bilirubin above 15 or approaching phototherapy within 3 milligram per deciliter, or the baby looks jaundice in the first 12 hours of age. Rate of bilirubin increment also can be used to identify the baby who will deliver significant severe hyperbilirubinemia. So they suggest if the rate of increment, it's coming here, okay. If the rate of increment 0.3 milligram per deciliter per hour in the first 24 hours considered significant, or 0.2 milligram per deciliter per hour after that. It's, if appropriate follow-up cannot be achieved, so discharge may be delayed. Statement number 9, they addressed about direct hyperbilirubinemia. Is common scenario coming to our clinic, baby with direct hyperbilirubinemia, what we can do, I will mention at the end of my presentation. So just summarization, so visual assessment should be done. This is the pathway we are following at Tawam Hospital. We tailored according to recent AAB guideline. So all newborns should have visual assessment for neonatal jaundice at least every 12 hours following the delivery. Bilirubin measurement should be done in the first 24 hours if the baby looks jaundice. Otherwise, bilirubin screening, universal screening for bilirubin should be done between 24 to 48 hours. Serum bilirubin should be done whenever transcutaneous bilirubin above 15 or approaching phototherapy or baby looks jaundice in the first 12 hours. Transcutaneous bilirubin is not accurate if measured in the first 12 hours of life or baby exposed to phototherapy in the last 24 hours of life, and whenever the reading is above 15. And this is a risk factor. Moving for treatment. Also, we have 3 options for treatment, either phototherapy or exchange transfusion or IVIG. So the general approach is to provide intensive phototherapy with maximum skin exposure. So intensive phototherapy, the definition of that is to provide a radiance of at least 30 centimeters square per centimeter square per nanometer. 30 microwatt per centimeter square per nanometer. So For that, the routine measurement of irradiance in infant receiving phototherapy is encouraged. A question now, how many of you measuring the irradiance while using phototherapy? Apart from Tawam? Actually, because we got machine now, we are measuring the irradiance whenever we use phototherapy, and we discover, and also many studies show that suboptimal dose of phototherapy we are using is a common. And in our unit also, it's sometimes, especially when we use fluorescent phototherapy, we see it's suboptimal. It's giving around 12, and the recommended is 30. So, and the intensive phototherapy ideally should be provided by narrow spectrum LED blue light. So no more fluorescent is recommended. With wavelength around 475, any light with wavelengths outside of 460 to 490 may provide unnecessarily heat and potentially harmful. Now, so the bottom line, intensive phototherapy is recommended when the total serum bilirubin reached to the threshold of phototherapy. And the AAB assume that you have to start immediately. Physician and family may choose to treat at lower level based on individual circumstances and preferences. For example, if the rate of bilirubin suggests there is likelihood that the next reading will exceeding the line, so it's better to start before discharging the patient. So, whenever about the sun exposure, this is common question. We are asked from the family. Now the AB clearly mentioned that although the sun exposure should decrease the bilirubin level, but there is some concern about the difficulties and safety for sun exposure. And sunlight now is not recommended. Moving to the new phototherapy chart, this is totally new. And also similar to 2004, this is non-evidence-based. But based on the evidence that the kernicterus doesn't occur until the threshold is well above the older threshold. So for that, they increase the threshold for phototherapy and for the blood exchange transfusion. And also, if you remember, in 2004, they put 3 categories based on gestational age and risk factor. Whether in 2022, they separate the gestational age from the risk factor. Practically what they did, because I did some calculation, they increased the threshold by 1 to 2 milligram based on the gestational age and risk factor. We'll give you an example how they did. Now this is the phototherapy. We have 2 charts now for phototherapy. One if there is phototherapy, when there is no risk factor, and when if there is risk factor. So if we start here with no risk factor, neurotoxicity, they start with age and extend up to 14. In the vertical line is serum bilirubin by milligram per deciliter. And each line will represent gestational age from 35 weeks up to 40 weeks. Whether if the baby has any of these risk factors, bilirubin below 3, immune hemolytic disease or other cause of hemolytic disease, G6P deficiency, sepsis, or significant clinical instability in the last 24 hours, here you will use this chart. This chart also days, and we have here bilirubin measurement. Each line presents gestational age, each line, but here the last line, see they clubbed in one line. So 38 weeks and above we'll consider as one line. For example, if we have now 40 weeker and no risk factor, usually we'll use the higher line. So higher line will be 2 days, for 4 days, will be around 20. But here, in the new chart, we'll have no neurotoxicity risk factor, so we'll use this chart. 4 days is 40 weeker, so we'll use the upper line. Upper line will be 22. So here they increase by 2 milligram per deciliter. If we'll use this example, 35 weekers and no risk factor, 48 hours. 48 hours will be around 13. So we'll use the chart also with no hyperbiliary risk factor and 35 weeker, so the cut will be 14. So whenever that serum bilirubin cross the line, we have to start phototherapy. During phototherapy, the phototherapy should be provided with the mother room. IV fluid is not recommended unless there is 2 cases we can use IV fluid. If there is evidence of dehydration cannot be corrected enterally, or the serum bilirubin measurement reaching to escalation of care, and will present what mean escalation of care. Feeding should be maintained during phototherapy to promote the bilirubin clearance. And whenever we started, we have to repeat the serum bilirubin again after 12 hours from start, or within 14 hours, within 12 hours from starting phototherapy. Then timing for frequent monitoring should be guided by the age, presence of neurotoxicity risk factor, and bilirubin concentration at the beginning of starting. Now, what other investigation should be done whenever we start phototherapy? They answered this question. CBC should be done, and you will assess. You have to do direct antiglobulin test for the baby, for the infant, in case the mother has positive antibodies or mother blood group is O or negative RH. Now, G6PD is optional to do. We have to do in some patient who has serum bilirubin increase suddenly or increase despite of intensive phototherapy or required escalation of care. So bottom line, whenever we start phototherapy, do CBC and assess. I will do direct antiglobulin test or I will do G6PD for the infant. When to discontinue phototherapy? So we said we start once crossing the line, but stop after dropping 2 milligram below the line. And check bilirubin rebound. Also, this is common problem. Checking the rebound between 12 to 24 hours from stopping phototherapy. In special circumstances, rebound should be done between 6 to 12 hours, but we have to repeat again at 12 hours of age if the baby received phototherapy in the first 2 days of life, or he has that positive, or he known or suspected of hemolytic disease. Now, home phototherapy, I know is not available option here in UAE, but also in US, they recommend to start, but the baby should meet all of these criteria, not one of them, all. So use LED phototherapy, gestational age 38 weeks and above 2 days of life, clinically well and adequately feeding, no hyperbilirubinemia, neurotoxicity risk factor, and no exposure to phototherapy, and serum bilirubin not exceeding more than 1 milligram from the threshold of treatment, and bilirubin, serum bilirubin should be measured daily. Moving to other option for hyperbilirubinemia is the exchange transfusion. Also here we have 2 charts of exchange transfusion, one with neurotoxicity risk factor and one without neurotoxicity risk factor. Also here we have age and serum bilirubin. Each line represents gestational age, and also here they clubbed 38 weeks and above in same line. Now, if we can see here, this is a dotted line. Also already it was in old chart. This means there is still uncertainty about doing exchange transfusion in the first 12 hours of life. Now, bilirubin to albumin ratios, they suggest now some numbers, and this ratio can be used in addition to serum bilirubin in determining the need for exchange transfusion. They suggest about 8 for low-risk patient, 7.2 for medium risk, and 6.8 for high-risk patient. IVIG also one of the options, and it reduces the blood exchange transfusion with the baby with isoimmune hemolytic disease and baby who reach to escalation of care and should having isoimmune hemolytic disease and the serum bilirubin reach to escalation of care. The dose is 0.5 to 1. There is concern about causing NIC in full term currently, some studies suggested. So moving to escalation of care. Escalation of care means whenever the serum bilirubin approaching the exchange transfusion by 2 milligram. So this is the exchange transfusion line. This is the phototherapy. 2 milligram, within 2 milligram or above the exchange transfusion, this is called escalation of care. This is an emergency, and they suggest to start pathway of escalation of care. The escalation of care pathway is to admit directly to an ICU, and start IV fluid, send a bunch of lab, prepare for exchange transfusion, and consider IVIG in case there is immune hemolytic disease. Now, and repeat bilirubin every 2 hours. Whenever the baby showed acute bilirubin encephalopathy or repeated bilirubin continue above the line of phototherapy, here you have to start immediate exchange transfusion. I will give you an example here. So now we have this baby, 2 days old, 35 weeker, and the bilirubin is 1 milligram above phototherapy. So what is our management plan here? Is phototherapy. So we'll start intensive phototherapy, and we'll do CBC, and then we'll think, shall we do G6PD or shall we do that based on the scenario of the baby? Now, we start intensive phototherapy. When to repeat the bilirubin? Bilirubin should be done within 12 hours of starting phototherapy, and we repeat it now 1.6 below the threshold. So our plan here, according to AEB, is to continue because it's not dropped 2 milligram below the line. So we continue and repeat within 12 hours again. We repeat after 12 hours again. Here this 3.2. Safely we can stop the phototherapy, but we have to repeat for rebound. So rebound, we said 12 to 24 hours. Okay, so we repeated. This is here. What this is here mean? This is escalation of care. So we have to activate here escalation of care, and this is the escalation of care recommendation. Admission to an ICU is a must in this. Post-discharge follow-up, as we know, we used to use botany nomogram, and we put high risk, low risk, low intermediate, but now it's drawback. It's drawback because it's not considered gestational age, and neurotoxicity risk factor also is created from population. They exclude the DAT positive infant. So instead of that, they said, let's measure delta TSB. So you will hear a lot now in the physician, we say delta TSB. Delta TSB is the difference between the bilirubin concentration and the threshold of phototherapy. And then we'll give you this table. Based on the number of delta TSB, the difference, how far the reading from phototherapy threshold, will give you the action plan. Let's take an example. This baby, ready for discharge, and serum bilirubin is 11, and 16 is the threshold of phototherapy. So the delta TSB is 5. We'll go to the table, 5, it's coming here. We'll tell you, go do serum bilirubin measurement 1 to 2 days. Serum or transcutaneous bilirubin. Also, if you don't like the table, there is colorful chart. You can use it. For example, this is 38 weeker, according to our example, and no neurotoxicity risk factor. 2 days of life, and bilirubin is 11. It will come in yellow zone. Yellow zone will tell you here, is it 1 to 2 days of life? Parents' education is very essential, and we already pre-designed the leaflet to be given to the parents in English and Spanish. And they highly recommend that before discharge, all families should receive written and verbal education about neonatal hyperbilirubinemia. Also, should receive information including the date, time, and place of follow-up, and bilirubin and hospitalization information, including the risk factor and last bilirubin measurement. Prolonged jaundice, as we said, this is common scenario when we consider as prolonged jaundice. Is it 3 to 4 days of life for the breastfed infant, and 2 weeks for formula-fed infant? And whenever the baby has prolonged jaundice, direct bilirubin should be measured. And also, not only to measure the direct bilirubin, also we have to review the newborn screening result to see, to rule out some disease like galactosemia, hyperthyroidism, and tyrosinemia. Now, the direct hyperbilirubinemia is defined above 1. No more 20% from total. Is it above 1? And the positive predictive value of biliary atresia and other causes can be greatly improved with repeated measurement within few days to 2 weeks. So no rush to start for investigation. You can give some time for the baby and measure the direct bilirubin within 2 days to 2 weeks, and then you can decide for the next step. Anytime we have direct hyperbilirubinemia, GI team should be involved. So, take-home message, jaundice is a common issue in neonatal period. Efficient phototherapy should be started immediately whenever it's indicated. Although the incidence of kernicterus is low, however, due to devastating outcome, universal screening and monitoring bilirubin is essential to prevent it. Each hospital should have a clear pathway for management of neonatal jaundice and assess the efficiency of phototherapy regularly, and parents should receive written and verbal education about neonatal jaundice. Any bilirubin reading that reached to escalation of care zone is considered an emergency case, so admission to an ICU directly, not through ER, and activation of escalation of care should be done on same time. Here we finish before time. Thank you. We have 2 minutes.
Next,
Thank you.
Thank you, Dr. Mustafa, for this debatable update in the guidelines of AAB regarding hyperbilirubinemia. But to be honest, I couldn't follow it until now. I'm not that courage to send a baby home who is 4 days old with TSB 18 milligrams and no problem, you can go home and wait, come tomorrow. Until now, I couldn't do that. It's my pleasure to introduce our next speaker, Dr. Iftikhar Jan Suleiman. And Dr. Iftikhar is a clinical professor of surgery in Khalifa University. And he's a consultant and chair of pediatric surgery in Sheikh Shakhbout Medical City. And Dr. Iftikhar has more than 33 years of pediatric surgery experience at the most prestigious institutions in UK, Pakistan, Japan, and UAE. And mashallah, he contributes in a huge number of publications in well-known medical journals. So let's welcome Dr. Iftikhar. He will talk to us today about advances in surgical management following severe neck. Welcome, Dr. Iftikhar, with us. Welcome to you.
Thank you so much, my dear friend, for the wonderful introduction. And I take this opportunity to thank my friends, Dr. Eman, Dr. Junaid, and all the neonatology team for inviting us. I was just listening to the lecture, and I was praying, thank God I am not a clinician, how I will remember all these data and things. So all we do is we do the things, and you are the one who actually prepare all the ground for us. So I've got nothing to disclose. The only thing is I steal nuts from the office of Dr. Junaid and Dr. Ali. That is the only thing. So I've got that is the only association. So NEC is a life-threatening complex condition. It has got a multifactorial causation, and we know about it, and it may lead to a significant physical and neurodevelopmental disabilities. Now, today what we will do is we will try, sorry, I've got a sore throat, so my voice is a little bit cranky, but just bear with it. So today I would like to actually answer some of the questions which are commonly asked from the surgeons. And we will also discuss about the surgical management of NEC. And the most important thing is that working together, how can we get the best outcome in patients with the NEC? Now, it was a surgeon, centrally, who first hypothesized about the causative factors for which are the essential component for the causation of NEC. And that was ischemic injury to the intestinal mucosa, bacterial proliferation and translocation of bacteria through the mucosa, and availability of metabolic factors, which you know, altered the body immune response. I'm not going to talk about it. You know very well more than what we know about it. But the mechanism of injury is important because that will tell us about the management of surgical management, how we plan in these patients. So NEC, we know that it happens in premature baby. It's a very classical scenario. The babies are small. There is a ischemic insult to the intestine, and the bacteria proliferate. They translocate. Translocation means they go through the mucosa into the intestine, where they rapidly thrive, and then they cause various degrees of necrosis of the intestine, and they can cause peritonitis and cause significant fluid and electrolytes imbalances, and then they cause a loss of a portion of the intestine, and leading to short bowel syndrome or sometimes to death. And our aim as a clinicians and as a surgeon will be to provide an environment so we can do the best outcome in these patients. I'm not going to go into the detail of Bell classification, but as a surgeon, I need to know three things. One is that Bell classification is based on the systemic signs, abdominal signs, and radiological signs. So we have to understand these, because if we don't know these, then it will be difficult to treat those patients. So Bell classification, to make it simple, the Bell stage 1 is a suspicion of NEC. This means a patient, we suspect that there is NEC. Bell stage 2 is a definitive NEC, but it is not complicated to that stage where it needs intervention. And advanced NEC, that is what we will be discussing today, which is the Bell stage 3. Now, in a classical scenario, what happens is that when the patient comes to us after suspecting NEC, most of the time you may not see clinical signs on the abdomen, and there may be a simple flat abdomen with abdominal distension, so that is the earliest sign. But then you see babies with severe sepsis, and of course, in the ultimate stage, there will be cellulitis and edema of the abdominal wall. Now, what we do is, when we suspect a complicated NEC, we do go for certain sort of imaging studies. And we know that in the early stages, there is bowel distension, then persistent dilated loops, pneumatosis intestinalis, portal vein gas, and pneumoperitoneum. So this is how it looks like when we see these patients. And in the initial stages, you may not see anything at all except that the patient is not well and he has got a distended abdomen. But what you find is, if you do serial X-rays, you will find that the gas pattern has not changed over the last few days or sometime over the weeks in the same baby. And this is called that there is a persistent dilated loops. And these persistent dilated loops are indication that this intestine has got an inflamed bowel and there is some degree of edema and the swelling of the intestine, which is not letting the intestine to work normally. But at this stage, we know that there is no perforation because there is no free gas. But the hallmark of NEC is pneumatosis intestinalis, which in the early phase may have just bowel thickening, but as you move forward, you will find the gas in the intestine, which is very, very obvious, and sometimes you can see the gas in the whole of the stomach or in the rest of the bowel walls. Now, when that is the situation, now this is a serious situation, and this patient is at risk of having serious complications. And the last, of course, the most serious complication will be that there is a perforation, but you may not see it on an AP view. You have to do a lateral decubitus film to see the gas in the upper abdomen, and that is how you will diagnose pneumoperitoneum if it is not clearly seen. But ultrasound can be a very good adjunct to your investigations, because ultrasound can tell you about the bowel wall thickening. It can tell you about the free fluid in the abdominal cavity. It can also tell you about the portal vein gas, which you may not see it on the X-ray, and it can also tell you about the small pneumoperitoneum. So sonography and X-ray are, both of them, they are very, very helpful tools for the diagnosis. Now, often, when we are discussing in the morning rounds, and Dr. Faisal will say, Iftikhar, do we need to do a contrast study on this patient or not? So this is a piglet model, and people have done these studies. And what they found is that the only thing which happens if you do a follow-up study will be, theoretically, a sluggish intestine movement. But having said that, contrast study, gastrographin, shall not be used in acute NEC because of the risk of more damage to the intestine. And therefore, the role of contrast study will only be once the baby is fine and we are looking for strictures for the treatment or closing the colostomies, that is when we will use the contrast studies. There are some other techniques, actually I don't want to go into the detail of all the diagnostic modalities because once we have got a diagnosis, the question will be how to manage it. Now, most of the NEC will be managed conservatively, and what we do is we do control of sepsis, nutritional support, we do the management of body fluid dynamics and other sportive management. So you know better than me, actually. I learn every day from you guys. What happens is once there is an NEC, nearly half of them will actually get better with the conservative management. And the half of them will ultimately develop some progressive disease of the intestine, which will require surgical intervention. And out of these half, 1/3 of them may eventually die. But having said this, all depends upon the center we are working. Now, if you are working in a center where you have got a high mortality, you are a good center. Why? Because you are getting very small babies, you are getting complex babies, and therefore it's just like congenital diaphragmatic hernia. The mortality of the best center is the highest, and mortality of the centers which are getting the best results is the lowest because they are not getting the patients when they are very small with complicated cases. The first actually thing which I want to say as a surgeon is that if you have got a baby with NEC, don't try to prick several times to get the vascular access. I know in our team, they immediately put a central line or a PICC line, which is the best thing to do. And what we agree always is that whenever there's the slightest doubt for getting a vascular access, just go for a Broviac line because this patient who has got NEC will ultimately need sampling and a good vascular access for the day-to-day care, and TPN also. The surgical management for the complicated NEC has not changed in the last several decades, and surgery is mostly indicated for the bowel perforation. And usually the NEC babies are unstable, and bowel is at various stages of ischemia. It's not all the NECs, they are same. It is not that you will get the same picture. And today I will take you to the operating theater now to see what we actually find when we see NEC babies. And our aim always is to have what we call a damage control surgery, that we are not there to do some heroic procedures. We are there to save the bowel as much as we can and to remove all the infected material and to do as minimally as we can because these are premature babies, sometimes 500-600 grams. So it is the doing some heroic surgery is not the aim and the goal. So indications are what we know, all of us know, that if there is a perforation, if there is peritonitis, pneumoperitoneum, and babies which are unstable or there are abdominal signs, there are indications for surgery. And these are some of the abdominal signs which you will see, and this is pneumatosis. Now the first thing, every morning when we go, all our neonatology team will ask, oh, this baby has got a premature 800 grams now, there is a perforation. Shall we put a drain or shall we go for do surgery? And actually, somebody will ask me always, shall we do laparoscopy? Okay. So all these things are possible. Now, to answer this question, I think we have to understand one basic principle of what happens in NEC. NEC is like an abdomen having an abscess. And any abscess, the basic principle of surgical treatment is to drain the abscess. We don't see the abscess which we see in the body, like a localized abscess which the staph is caused, because staph localizes the abscess. But these bacteria, intestinal bacteria, they don't localize, and therefore there is a big abscess. And your aim is to remove that infected material. And if you can remove that infected material, you can actually save the baby from a lot of complications. So that is our first, basically, goal. The second is to preserve the partially necrotic bowel. So not all the intestine is gangrenic. There may be a portion which are not gangrenous, but they are at a level where they can improve the circulation. So in these cases, I think you can always save those bowel. We'd avoid unnecessary bowel resection, but if there is a gangrenous bowel, and if we can safely remove it, we will remove that one. Now there is a study which definitely shows clearly that if we do early surgery in patients who have got NEC, instead of putting a drain, the risk of having short bowel syndrome will be much higher. And the reason is that when you go in, you do some harm, and then there is a potential for resection of bowel, which could have been saved. So if you put a drain, so that will give you the time for the intestine to recover, and then you do surgery when the situation is more optimized. Now, putting a drain is basically should not be a surgical issue. It can be done on the bedside. It's done under local anesthesia. Sometimes air pocket is not clear, so you can do an ultrasound guidance. just simple local anesthesia, simple cut, and you can even put some glove finger or something and drain the fluid. And just like an abscess, once you drain the fluid, infected fluid, you will see a significant improvement in the patient. This is what you see. This is a patient with an abscess, and you can see the drain here. After putting the drain, everything is gone. So what happens? What happens when you put a drain? So there's a good chance that the patient may not need a surgical intervention. He may just get better. So once you decide for surgery, the next question is, what do you find? And let me take you to these pictures which will show you what we find. In the first scenario, what you will find will be a patient who has got a hyperemic bowel with a lot of the normal intestine, and there is some bruising of the intestine. Now here, you don't have to do any resection, anything, and just clean the body, take out the fluid, and that will improve. And then, as the severity of infection increases, you will see more and more ischemic areas. Even in this patient, there is no rush to remove anything, and we just clean the bowel, and we try to correct the, sometimes there is malrotation or other factors, we clear that. But at the other end, more and more progressive disease, you will find perforations and necrosis of the intestine. Now, this is an area which is where you will have to be careful. You don't want to remove any bowel which can be saved. And I will show you how we do it. And if there is a really, really ischemic bowel, then you can resect it. But luckily, in this patient, you have got a large portion of the intestine which is not necrotic and which can be saved. Sometimes you find multiple segments of the intestine affected, and this will be another scenario where you may have to do multiple excision of necrotic tissue and then making multiple stomas. And sometimes what you see is that there are patchy areas of necrosis on the intestine. But the worst case scenario is this one, and this is actually you are seeing the whole intestine necrosed, and what interesting thing is you can see a nematosis on the intestine of this patient. Now this is the fear of a surgeon and also of a neonatologist, because here there's a good chance that we will lose most of these patients' intestine. So what to do with these patients who have got a total intestinal necrosis? So this is the same patient, we have put a drain and we do a laparotomy, and we expect that when we go in, we will take out the fluid and maybe we will take out the intestine. But when you go in, all you find is all necrotic intestine. Now here, your judgment will work. Don't try to go into the abdomen and try to correct the things. We put a drain again and we close the abdomen, and we will come back after some time after doing the investigation and see how much intestine was saved and how much was needed resection. Sometimes you go in and you find that there is a multiple segments of the intestine, they are actually gangrenous. So the area which is overtly gangrenous, we have to remove that. And then what we do is we repair the other important thing is to measure the length of the intestine. And here you see there is a perforation here. We repair all these perforations which are there. And there can be multiple areas of necrosis, and we will just repair them, and we will make a stoma, because that is the safest way of saving the intestine, and we will come out. So we have got these 4 scenarios that we have got clearly, there is only a septic fluid only, we remove that, we resect the localized portion, and then we do a major necrotic resection, and here, where there's extensive necrosis of the intestine, I don't know what we do, but that is some area, we just put the intestine back, we don't do anything, we come back. Now, there are several other techniques which can be used. If we have got multiple segments of the intestine affected, we can make multiple stomas initially, and then come back and close those stomas. And there is a clip and drop technique that you clip the intestine, drop in the abdomen and come back, and then there are a lot of other techniques. But the technique which I found was really helped us is one of our patient was a second look laparotomy. This was a patient who had a malrotation with NEC. And what do you think we should do for this patient? Resection or no resection? Resection. So actually this looked like a very ischemic bowel. We put a warm cloth, untwisted the intestine, and we closed the skin. And what is a planned second look laparotomy? That in the initial we don't resect anything. We only close the skin, and after 24 to 48 hours we will come back and see the intestine. And as you can see, the intestine has recovered nicely, and this patient was completely well without any resection, and he went home. And this is a very classical example of avoiding unnecessary resections in patients who have got short bowel syndrome. Unnecessary resection, otherwise they go into short bowel syndrome. So that is the beauty of second look laparotomy. So just compare this intestine, and this is the same patient. We published this case, and this is something really interesting that which we need to know. Now, after NEC has been operated, the next step is what will we do? So whether we have done, if we have done a localized resection and we have done an anastomosis, there is a good chance baby goes home without any sequel. Those who get stomas will get a second surgery for closure of stomas. And sometimes they do develop strictures, and we need to do stricturoplasty or excision of strictures. But our fear is the development of short bowel syndrome. What to do if there is a short bowel syndrome? Now, this is a case who is a stricture. We just excise it and anastomosis. I'm not going to go into the detail. But if there is extensive loss of intestine and short bowel syndrome, that is what is our fear, and what will we do? So if there is a loss of, if there is only 40 centimeter of intestine left, small intestine, with no ileocecal valve, this is the one which is at a higher risk of developing serious complication. And if there is an ileocecal valve, even with a smaller length of the intestine, there is a good chance that the child will survive. And they have got all these issues which you can expect in these patients. And we can put the patient on short bowel syndrome, on home parenteral nutrition or some other things. But the most important thing is the proper documentation when you are doing surgery for NEC. So what we do is that we make a diagram of all the areas which were normal and all the areas which we resected. And then, for example, in this case, if you see this patient, what we are showing is that there is a 37 centimeter of the intestine left with a ileocecal valve when it's anastomosed, and this patient went home because there is ileocecal valve and a colon for absorption. So that is what is the outcome in these patients. Now, with the ileostomy stroma, there are a lot of complications, but like stoma prolapse. But the main problem with short bowel syndrome is the, nutritional problems, dehydrations, electrolyte imbalances, and there are several techniques which are used, and I'll just briefly go through the 2-3 techniques. Now, one technique for increasing the length of the bowel is a Bianchi's technique. That in here, what we do is that we divide the intestine into 2 parts using the mesentery, and we make 2 loops from 1 loop. And this is a technique which normally we cannot use in NEC because the mesentery is not healthy. The technique which we use is a step procedure. In a step procedure, we do multiple serial lengthening procedure or enteroplasties. So this is how we do the step procedure at SSMC. This is a child with short bowel. We close the stoma to make the intestine show a bigger, and then these are the step incisions markings. And the beauty of this procedure is that you do this procedure without damaging any part of the intestine. So you can get a length of 10 to 15 or sometimes 20 centimeter in one go. So that is the step. Then we use staplers to actually divide on the mesenteric and the anti-mesenteric border, so that ultimately when we open them, we get a much longer length of the intestine which was initially there. Small intestinal transplantation, I had the privilege of working in Japan for 1 year on small intestinal transplantation. Luckily, that was long, long ago, 1993. Many of my younger colleagues were not even born, or maybe some were born. And so I thought at that time that we will be able to get a good success in small intestinal transplantation. By the way, this is in rats what I was doing, not human beings. And, but it took a long time. After 30 years, there are successful transplantation done. Now there is a better immunosuppression regime. And we were the one, our center, Kyushu University, was the one which actually invented the FK506, which is the immunosuppressant which is now used. A combined liver intestinal transplant and multivisceral transplants gives a better results than isolated intestinal transplant. And I think I don't have the time to discuss that, but the good news is that a recent study shows that patients who have got intestinal transplantation, there is a very, very good chance of survival. One question is about laparoscopy or laparotomy. Laparoscopy in children who have got NEC is not difficult, just like we are doing it on all small babies with hernias. But the problem is not only the space, but the risk of having a lot of CO2 intoxication. And also, we are working in an inflamed space, so I don't normally prefer laparoscopy. The role of laparoscopy is basically in isolated bowel perforations or a gastric perforation. Now, these are the perfect cases where you do laparoscopy and where you will get the best results. So, my friend, I'm coming to the conclusion. And when I was preparing this presentation, and I saw seeing all these horrific pictures, one may think that NEC is a very, very bad disease, or what we will do. I reviewed all my cases, and actually, only few of them, only one of them was referred for, one or two, for intestinal transplantation. Most of the patient, even with this bad-looking NEC pictures, these are all from SSMC. They all survived. They went home. And the other amazing thing is, I didn't see a lot of them coming with intestinal lesions and intestinal obstruction. So Allah subhanahu wa ta'ala has got a very good way of recovering these babies. And with the help and support of my NICU team, they do a great job. This is the NICU set up in SSMC. And we were very grateful, and I'm sure we have got similar setup in rest of our centers, and our neonatologists are doing a great job in, preparing these patients, and only few of them will come for surgery, and end of the day, I think, of course, it's a challenging condition. All these procedures are there, but the most important thing is, if we join hands, if we work together as a team, we always get the best result. Thank you so much.
Thank you very much, Dr. Ftihar, for a very interesting lecture and up to date. Can I ask the speaker to the stage for question, for panel discussion?
I have 5 questions.
No. Every time, Dr. Junaid.
Can I?
Okay, of course.
Okay, thank you very much. Amazing, and we put Iftihar in the last for all these pictures, and thanks a lot for appreciating us and my team in NICU. I have a few comments, and I need Professor Eric and Faris also help me. It's not related to Iftihar. The comments on the Mustafa talk, that this guidelines, I have my own doubts about that. First of all, the visual seeing the baby, because I can see yellow, I cannot see the yellow baby. I can see the dark, I can see not the dark. So the universal ribbon screening has to be there to me. The second thing is that not all the units has LED. So the implement and the follow-ups are not that great here. The implementation of these guidelines, I think if Faisal is here, is about July 1st. I have my own doubts, okay, on that. Before Mustafa, I need Professor Eric comment on these guidelines.
Thanks. So I don't represent the American Academy of Pediatrics, but I'll pretend like I do. I think that one of the driving factors of these guidelines were that the authors thought that phototherapy was being used too much. And so there really was a drive to try to decrease the amount of phototherapy that was being used. So I think that that's one of the reasons why they've shifted the curves to recommend less phototherapy, because of some concern about potential risks of phototherapy in the long term. So that was really a driving factor in this, and also that, but that being with the caveat of an effort to try to prevent any cases of kernicterus. So I think that there was a lot of confusion when these first came out in the United States. There was a lot of pushback because people liked the old guidelines. They were used to the old curves. But I think people have settled in as these have become better known. And I think so even though I agree with you, there's been some pushback, I think once you read through what the recommendations are, and I think they were very, very nicely summarized, it's not as complicated as it seems. I think that they specifically recommend against visual determination of jaundice because we're not very good at measuring that with our eyes.
DCB.
Yeah, so we have continued to do the universal bilirubin screening because, and here in our part of the world, the follow-up is not that great.
Yes.
Okay, they don't come in 1 day, 2 days, and Dr. Taseer and Dr. Faisal is with the DOH, and they know that there are many cases for that. So that's why I asked the question of Mustafa. Okay.
Okay, Monica, wait, one from here, one time, one.
So only just I have comment, Dr. Junaid, about visual assessment. For AB, they said visual assessment, and whenever we know the visual assessment is not accurate, not reliable method to assess for needing for phototherapy or for starting the therapy, but at least to screen for the baby who's at risk for developing hyperbilirubinemia in the first 12 hours of age or 24 hours. A universal screen is still recommending.
Yeah.
They recommended 12 to 24 hours, but they recommend initially that each country has to design their own protocol for that. At the home hospital, we sat together and we said we'll do universal screen at 18 hours, not at 24 to 48 hours. So, and the main drive for changing now, because as we said, the evidence base didn't, the evidence base currently showed that all the threshold is too low, that we are starting phototherapy without any indication, and the incidence is continue low in kernicterus. For that, they increased the threshold, but they said whenever you want to start, give you option to start 2 below. So it's fine. You can continue using the old one. This is an option. But whenever you start intensive phototherapy immediately. So for that, we design our own protocol at the home hospital, but no time to present it.
Yeah, my question is for 3 speakers. Can I?
No.
First question is for Professor Eric, because about the probiotic, like, of course, we have seen that different studies have used different strains, different, concentration, and that could be the reason, one of the reason for having so much of differences in results. Other than that, because I have seen, like in Australia, they have found a lot of, positive results with the probiotics. And would it be genetics playing a role in this? This is my one question. And the second is like, those studies from Australia, they have found that probiotics are working more when you are using breast milk rather than, you're using formula milk. So, and the other studies, they didn't see those. So that could be the reasons for these differences?
To your first question about genetics,
Yeah.
I don't have a good answer for that. I think genetics, plays a role in everything, so it certainly is possible, but I don't think that I think that when you look at across different populations, there probably isn't that much of a difference. To your second question about utilization of breast milk, yeah, absolutely. I think that there are variable results with probiotics. And I think my point is that there are so many differences between NICUs that if you institute probiotics in your NICU, you may see no effect because of other factors that are influencing necrotizing enterocolitis, whereas in another NICU, you've got a very low rate to start out with, and probiotics may be additive. And so I think that that's why it's so important to institute the things that we know work before you decide that you're going to use probiotics. But I think in the United States, I would say probably about 25% of NICUs in the United States are using probiotics. They claim good results, and whether or not that's just a temporal trend because the overall incidence of necrotizing enterocolitis has been going down because we use a lot of breast milk and donor breast milk. So I think it's a complex subject, and I wouldn't absolutely say don't use probiotics, but go into it with thoughtfulness about why you're doing it, what product you're using, and monitor it very closely.
Thank you.
Okay.
Dr. Faris,
Because of out of time, Doctor, give a
thank you
chance
very
to
much.
the other one because you know that we are already late.
So I have
Dr.
an easy question and a hard question. So the easy question is start Dr. Iftikhar first. No, it seems like there's an agreement between all the surgeons about not rushing to the surgery from the onset of NEC and do the Penrose drain first. Give some time for stabilization and maybe you avoid going to the OR. But this agreement happens, what happened after you put the drain? How long you wait for the drain? What's your criteria for when to remove the drain? Or what's the criteria to go to surgery after stabilization? That's one question. But Dr. Faris, I promise you I have challenged your proposal. So
I don't know the answer.
I'm not going to kill you, but I'm going to try and challenge you. So there's two grounds I'll challenge your proposal. One on clinical ground, second on financial grounds. On a clinical grounds, I think the issue with avoiding to give protein that's bovine protein, not to try to mix it, because the bovine protein is what's the harmful effect when some people implicated with the neck and exposure to allergy and all that stuff. So I don't see any benefit from giving bovine fortifier when the mother provides milk. This is the first one, and I don't think there's a clinical, you showed a lot of really beautiful studies, but I don't think any study looked at the safety of this proposal. So if there's a study that's compared human milk fortifier with bovine milk fortifier with human milk to exclusive human milk, then we will talk if there's any comparison head to head. On financial grounds, when you look at, is it 25,000 better than 50,000? Well, to me, maybe it's not, because when you look at the quality, you look at every disease and how it affects the individual. So, for example, like you provide the quality for chronic lung disease, and you look at, hospitalization, loss of school days, loss of income from the parents because they have to take their child to the hospital and stay with them. So quality is it's a disease in specific. It's not really solely on a GDP. So that's my questions, but we'll talk about it later.
So thank you for asking me the easy question. So I've got an easy answer. So if once we put a drain, there are two scenarios. If it was an isolated perforation, it will stop bringing anything out. Baby passes stools, you don't do anything, you just watch. If he starts producing just the stools from the stomach, from the where we put the drain, and we have a daily meeting with the NICU team, and when the baby is fully stabilized, we just go in. There is no time to wait for there is no timeline. It may be just few days to sometimes few weeks.
But what's your indication of, like, do you follow the perforation? I would say perforation persisted over 2 or 3 days.
Yeah, perforation is fine. The idea is to give time for the intestine to recover whichever the ischemic intestine was there. So the infected material is out, the abdominal compartment is relaxed, so perforation will not kill the baby. The killer factor will be the infection initially, and it takes normally a long time for the babies to recover from this acute phase. But it all depends upon the clinical signs on the abdomen, how much is the output. If, for example, it's a very high output proximal area, we may like to go in. If it is a low output from the distal one, so we may can wait for adequate time. So it's not like a fixed time. It all depends individually about the size of the baby, about the clinical state, about the sepsis control, everything.
We like numbers, as you mentioned, the neonatologists like numbers. So I would like to commit you to a day or two, but that's kind of debatable.
Normally, it's very difficult because, as I said, the severity of involvement will be different in different NECs, and there's a good chance that if the patient is clinically becomes stable, then there is a isolated perforation. But it's very difficult to give a number. I think it will be depend upon the clinical state of the patient.
Right. Thanks, Dr. Ayman, for 3 questions. The first question was about the proteins that are in bovine-derived fortifiers that might be harmful. I have 2 answers to that. First, no matter how harmful they are, there are enough randomized trials, about 9 or so that I showed, that showed no difference in the outcome, at least in the major outcomes, of preterm baby who received bovine fortifier versus a human fortifier. That's one part of the answer. The other part of the answer, the milk is not only about the nutritional aspect, which is the protein. You have also all the cells that are in the milk. You have also all the growth hormones that are in the milk. Plus you have some 50 components that are there between immunoglobulin, lactoferrin, and lysozyme, and name it. So hundreds of elements. And all of those are not directly related to the protein, whether they are bovine or not. So, but no matter what is the theory, thank you for the question, no matter what is the theory, the evidence based on statistics didn't show that paying 47,000 for human fortifier versus paying 700 for bovine fortifier made any difference to the major outcome, even to the minor outcomes. So based on that, I think if I had money, I say always human milk or human fortifier. But I wouldn't say that it is cost effective to make that choice. This is about the protein. Your second question was whether there was enough study showing that human milk diet, which is not exclusive human milk diet, made a difference. And honestly, there are enough studies. There are many studies, because it's quite confusing that when you review the literature on exclusive human milk diet, you find some they gave partially, Cochrane review, they include 3 studies that included bovine, another 3 studies that didn't include it, and they combine it in one thing. So it is quite an undertaking to go and separate those. But I found, I can't tell you the names, but many, at least 4 or 5 studies, and it's clear that in the literature that human milk is beneficial. So I don't need, and like it's a bit like saying water is wet, as I gave. So breast milk is beneficial. So the question, but we demonstrated that bovine milk, bovine fortifier doesn't make a difference. So to me, it's clear. I cannot go and recommend something if another thing reduce. Odd ratio for NEC is 33.33, for ROP 0.33, for BPD 0.78. So these are the points. What was your third question? Yes. Your third question was about the cost effectiveness study. I agree totally with you on that. I said clearly when I was presenting, it is a quasi-science because it's not a cost effectiveness per se, but there are maybe some 8 at least cost effectiveness studies that are out there. I reviewed them all, but they don't apply to us. The way they pay us here by DOH, at least my hospital, The maximum they pay is 487 dirham, which is 132,000. Even if your patients stay 1 year, you have a plateau. And I can't use whatever they have as analysis in other countries to apply here. So I didn't do a cost effectiveness, and I agree with you, it is not the best cost effectiveness. But take it simple. You have something that reduced NEC by 60%, by ROP by 60%, BPD. So I'm sure that the number need to treat, I calculated it 6.
Yeah, just a quick follow-up. It seems to me like your proposal is punishing the mother who giving us breast milk by adding bovine milk to her milk, and rewarding the mother who doesn't give us milk by giving her exclusive breast milk. So it's kind of like, to me, it's not really giving the right message.
No, it's not punishing, but the point, you have a point that in places like in the US, North America, Europe, where milk banks are there, many mothers says, why should I fight expressing since there is milk that coming from the bank that doesn't cost much money?
And we have, by the way...
But there is no punishment since...
By the way, there's Islamic countries with blood
This is
bank,
my
with
friend, I
milk
cannot-
banks. Turkey have one.
He's my friend.
India has one. So milk banking is not incompatible with Islamic teaching. And there's another source of milk, is surrogate breast milk, which we use it actually very regularly in Tawam. As long as you identify the source of the milk, it's Islamically acceptable. So there's another two sources, really important source of...
Excuse me, but because the other speaker is waiting online. So I'm very sorry, يعني.
لا خلاص, we're finished. Thank you.
There is a request from the other triplet.
So we'll continue. We'll continue offline.
So thank you very much, and we are thankful for the speaker, and we will start. There is no because we want to finish.